Welcome back to the Ninja Nerd Podcast. Today we're talking about glomerular diseases. That includes nephrotic syndrome and nephritic syndrome.
Yeah, it's a good one. I think also another thing is nephritic syndrome. Sometimes we also refer to that as glomerulonephritis too. So we'll kind of have a little bit of discussion about that.
All right, cool. So we have two cases, one on nephrotic, one on nephritic. Let's go ahead and start with case one and get right into it.
Let's do it, bud.
All right. So we have a 65-year-old woman presents with persistent leg swelling and difficulty breathing at night. History of her HPI. The patient reports experiencing significant and progressive leg swelling over the past 6 months, now involving her ankles and lower legs. She has noticed an increased difficulty breathing when lying flat, requiring multiple pillows to sleep comfortably. Additionally, she mentions the recent onset of frothy urine and unexplained weight gain. She denies any recent infections, changes in meds, or exacerbation of chronic complications. Her past medical history is pertinent for hypertension and hyperlipidemia. Her medication she's on is amlodipine and atorvastatin. And now for her exam. Her vitals, BP is 160 over 95. Heart rate is 88. Respiration is 18 per minute. Temp is 98.2 Fahrenheit. And her O2 sat is 95% on room air. For general, she is an obese female, appears tired. Cardio, regular rate and rhythm, an S4 gallop, no murmurs. However, she does have a 3+ pitting edema in both lower extremities. For respiratory, it is clear to auscultation bilaterally, no wheezes, no crackles. Abdominal is soft, non-tender, no bruits. Neurologic, alert and oriented, no focal deficits. And her skin is dry, it's excoriated, it's scratch marks, but no rashes. We do go ahead and order some labs for her. So we get some laboratory findings back, and it's the following. Creatinine is 2.0. Previously, it was 1.2 6 months ago. Her BUN is 40. Hemoglobin is 11. Potassium is 4.5. Sodium is 135. Phosphates 3.5. Calcium is 9.2. Albumin is 2.8. Her urine protein creatinine ratio, or UPCR, is greater than 3.5. GFR is 35, and her lipid profile is pertinent for elevated LDL and triglycerides. We do get some imaging. We have a renal ultrasound showing normal-sized kidneys with increased echogenicity, suggestive of a chronic disease. There is no hydronephrosis or stones present. For her echocardiogram, we also get that. And the echocardiogram reveals a left ventricular hypertrophy with a preserved ejection fraction. So, Zach, I know that was a lot of information.
Yeah.
But based upon all this information, I want to go over just a couple of questions to start us off with case one.
Let's do it.
So, does this patient have nephrotic or nephritic syndrome, and why?
Yeah, that's always the first thing to ask about when you're talking about glomerular disease. So the first thing I would look at is oftentimes the degree of proteinuria. The degree of proteinuria is really the biggest thing to look for. And what we like to see is something that's greater than 3.5 grams within a 24-hour period if you get a 24-hour urine collection. And the reason why is in nephrotic syndrome, there's podocyte injury and there's loss of the negative charge in the GBM. And so these patients lose heavy amounts of proteins. So if I see greater than 3.5 grams per gram, which is their spot ratio, so we just take a urinalysis at one point, that tells me that they're making a lot of protein over a 24-hour period. Oftentimes we try to say that this is usually a 1-to-1. So for example, if I see the ratio is greater than 3.5, let's say it's 3.5, that oftentimes, not perfectly, will say that it's likely that they're making at least 3.5 grams within a 24-hour period. So this is definitely nephrotic range proteinuria. The next thing is like nephrotic syndrome. It's not just proteinuria. You have to have other features. And so what I have to have here is I have to have basically proteinuria has to be greater than 3.5 grams in a 24-hour period, or a spot that's greater than 3.5 for the ratio. Second is I have to have low albumin in the bloodstream. So hypoalbuminemia. And in this case, it's 2.8. So it is low. All right. The next thing I need to have is edema. And this patient does have what we would say is edema, particularly in the lower extremities. So 3+ pitting edema. A big thing to remember here is oftentimes this is one of the common presentations for patients who have nephrotic syndrome is they come in with a lot of swelling and edema and weight gain. And the first thing that you want to have to think about is, well, there is other diseases that cause edema. Oftentimes the most common one is heart failure. And so what I would like to do is know what their heart function is. And when I look here at the echocardiogram, They have a preserved ejection fraction. They have some left ventricular hypertrophy, but no diastolic dysfunction. So it kind of like makes me think it's not really heart failure that's driving their edema. Cirrhosis would also be another one that can cause this because it can cause low albumin, but there's no underlying history of underlying cirrhosis in this patient. So I would think that that's less likely. And also, cirrhosis doesn't cause this degree of heavy proteinuria. So the edema is likely a result of nephrotic syndrome. And the last thing that you oftentimes need to truly make the diagnosis is hyperlipidemia. So elevated LDL and triglycerides tells me that this patient has proteinuria, at least nephrotic range, greater than 3.5 in a 24-hour period. They have low albumin, so hypoalbuminemia in the bloodstream. They have edema, which in this case, there's no other alternative cause of it, like CHF and cirrhosis. And then on top of that, they have hyperlipidemia. And that is oftentimes what we look for as the criteria to make the diagnosis of nephrotic syndrome. Now, with this being said, it's not always perfect, but when we talk about edema and nephrotic syndrome versus in other areas tend to be more within the facial area or periorbital area as compared to the more dependent areas and cirrhosis and CHF, but that's not always perfect. So again, I would say that this patient fits nephrotic syndrome as their glomerular disorder.
All right. So what complications should we be concerned for? What are we looking out for here for complications? Anything that's really kind of alarming?
So the biggest thing with nephrotic syndrome is whenever they have low albumin, you can't hold fluid into the circulation as well. So the oncotic pressure drops, fluid leaks into the interstitial spaces, and they can develop edema. Plus they have less the underfilling hypothesis. So they don't have as much fluid within the circulation. So it activates the renin-angiotensin-aldosterone system and they retain sodium and water. And so they could present with like pulmonary edema and pleural effusions. This patient does have like what kind of sounds like orthopnea or paroxysmal nocturnal dyspnea. I didn't get a chest x-ray to look to see if they have any, but I imagine that they probably have some degree of pulmonary edema or pleural effusion. It's a pretty common area. They can also it can actually develop ascites. I don't see anything here that mentions that the patient has any evidence of ascites, but pedal edema, which is usually pitting, is a very common one as well. Hyperlipidemia, we already talked about that one, is a big one. The other thing that I actually get really nervous about is when you dump a lot of protein into the urine, your liver compensates by kind of trying to be able to increase the production of lipoproteins. And that's where we see that elevated LDL and triglycerides. Depending upon the level of that could increase the risk of atherosclerotic cardiovascular disease. So I have to be on the lookout for that. But I'd say the other really big thing here, it's not mentioned, but I'd be very careful. As you dump more and more protein into the urine, it's not just albumin. You can dump immunoglobulins, and these are important for fighting off infections. And so these patients are usually higher risk for infections, especially from Streptococcus pneumonia. And the last thing I would also be really, really, really careful of here is when you dump proteins, you also dump things like antithrombin 3, protein C, and protein S, which are really important anticoagulants. And if you lose those anticoagulants, you're more prone to clotting. So other things that I would be on the lookout for if I think that a patient has nephrotic syndrome is hypercoagulable states. I'd be watching out for high risk for infections, and I'd be watching out for a lot of hyperlipidemia related complications like atherosclerotic cardiovascular disease. So that's what I would be thinking about, but I think their biggest manifestation is tending to be the edema factor.
Okay. So now, what is the likely cause of this patient's nephrotic syndrome? How do you determine that?
That's so difficult. It's like, because that's why oftentimes on the exam, it's just get a biopsy,
right,
and see if there's any kind of like an underlying primary glomerular disorder that's present there. I'd say it's always good to rule out kind of like systemic illnesses that cause secondary glomerular involvement. So for this, I always want to rule out diabetes. Does the patient have a history of diabetes? Get an A1C, check on that. And do they have any other, other manifestations of diabetes, like retinopathy or neuropathy or things like that? So that's one thing I would do is I would check an A1C.
Okay.
I'd also want to rule out amyloidosis. That's a rare one, but I would consider potentially for these patients maybe getting like an SPEP and a UPEP to make sure I rule out any kind of underlying, like a lot of proteins that are being deposited. And depending upon the findings of that, you could do a fat pad biopsy. And I think the last thing I would want to do is also rule out what's called a primary membranous nephropathy. And we can do that with an anti-PLA2 receptor. So that's kind of the way that I would start off. And then based upon that, I would kind of start ordering other tests. But oftentimes they say to obtain a lot of different tests. They'll tell you to get like an ANA an anti-double-stranded DNA to rule out like lupus. You could also check infectious etiologies like hepatitis B, C, HIV, syphilis. But those would be the ways that I would kind of start off. But most likely, I'm going to end up needing a renal biopsy to really help me to determine what's the likely cause, especially if there's no diabetes, there's no amyloidosis, and there's no anti-PLA2R. It could be really anything else, and I need to probably get a renal biopsy to nail that down.
It's funny because we already got a pretty good amount of lab work done for this patient.
All right.
So it's kind of interesting to see how much more lab work we can order for them.
Yeah, exactly.
So it's like almost like you start off with, a general idea, and now you're like really honing in.
Yeah, that's the whole concept is you get the patient who you think has nephrotic syndrome, and then you say, okay, I think it's nephrotic syndrome rather than nephritic syndrome. How do I figure out the cause?
Yeah.
And then in order to do that, really the best answer would be a biopsy, but check other things, at least an A1C, an SPEP, UPEP, and then check an anti-PLA2R. But you can add on other tests if you have a degree of suspicion for an underlying kind of glomerular disorder that has a secondary cause. And that would be like hepatitis, HIV, syphilis, et cetera.
All right, so let's go ahead and do the labs that you had just requested, labs and biopsy, and let's see what we come up with.
All right.
So we do get the serum protein electrophoresis, the SPEP, and that shows hypoalbuminemia with nonspecific gammopathy.
Okay.
We get the urine protein electrophoresis, the UPEP, that's significant albuminuria. We have a hemoglobin A1C of 5.9%, so we can rule out diabetes.
Okay.
We have the ANA, the anti-nuclear antibody, negative. The anti-dsDNA, negative. We do the infectious etiology, so we check for hepatitis B, hepatitis C, HIV, syphilis. They're all negative.
Okay.
And then we do finally the one that you requested was the anti-PLA2R antibodies, which comes back positive.
Okay.
Finally, we do the biopsy that you had requested, the kidney biopsy. Upon histopathology, we see subepithelial deposits and spike formation consistent with membranous nephropathy on EM. It has a granular appearance on IF.
All right.
So, Zach, a few more questions about these findings that we just kind of talked about.
Yeah.
Given the patient's labs, biopsy findings, what can you say now is the likely cause of their nephrotic syndrome?
Yeah, and so that kind of, whenever you have nephrotic syndrome, the differential is kind of somewhat wide. You have something called minimal change disease, you have focal segmental glomerulosclerosis, and you have membranous nephropathy. And oftentimes we define these as these are primary glomerular disorders, meaning that they really only affect the glomerulus. And then you have other ones which are systemic illnesses that cause secondary glomerular involvement, and that's diabetes and amyloidosis. So with the diabetes, that's off the table via the A1C. There's no history of diabetes, and usually they'll have things like retinopathy. SPEP, UPEP does not show any significance of lots of amyloid proteins, especially kind of like what's called AL amyloidosis, which is lots of multiple myeloma. So usually that would have lots of Benz-Jones proteins that would come up here present. So this is not significant. The ANA, anti-double-stranded DNA, these come back negative. This can actually cause membranous nephropathy. It's called secondary membranous nephropathy. Hepatitis B, C, HIV, particularly hepatitis B and C, they can cause secondary membranous nephropathy. And so can syphilis. HIV can cause what's called focal segmental glomerulosclerosis. But the big giveaway here is the anti-PLA2R. If that's positive, I want to say, if I remember correctly, the sensitivity and specificity of this is like, it's somewhere around 95%.
Oh, wow. Okay.
So it's pretty good. And you could honestly forego a biopsy if this comes back positive. However, I think a lot of clinicians are still in the area where they want to, err on the side of caution and get that biopsy, because if this is the case, you're putting these patients likely on immunosuppressants for a long, long time.
Okay.
And so you want to make sure that you nail down that diagnosis. But right away, when I see that positive, that's primary membranous nephropathy. I technically don't need a biopsy, but some will say just get the biopsy. When you get the biopsy, it shows this kind of what we call immune complex deposition, which is via the granular appearance on immunofluorescence, or IF. And then these subepithelial deposits with a thickening of the GBM, that's really consistent with membranous nephropathy. So it's minimal change disease. Usually that would have what's called podocyte effacement in a normal glomerulus. Focal segmental glomerulosclerosis would have sclerosis and cyanosis of the glomeruli with podocyte effacement. And then diabetes, usually that causes what's called Kimmel-Steele-Wilson nodules. And amyloidosis, you put a special stain, it's called a Congo red stain, and it turns like an apple green color. So all of these are not consistent with what I see here for membranous nephropathy. And then we've ruled out other potential things like amyloidosis off of the SPEP and UPEP, diabetes off the A1C. We've ruled out other secondary causes of membranous nephropathy like lupus, hepatitis B, C, and syphilis. And then we ruled out the secondary cause of focal segmental with the HIV being negative. And then we even confirmed even a double confirmation with membranous with the anti-PLA2R. So this is likely membranous nephropathy is the cause of nephrotic syndrome.
All right, so we have the underlying cause. We've determined that. Now I want to kind of talk more in like a stepwise approach of how do we manage the complications that we're going to be seeing here.
Yeah, let's do it.
So I want to start with edema and work our way down.
All right, let's do it.
All right, so edema, what do we do?
For this one, oftentimes you treat the underlying cause and hopefully, for example, for this patient, we'll talk about it later, you'll put them on immunosuppressants. And that actually will help to kind of suppress a lot of the damage to the podocytes and a lot of the changes to the GBM. And so you will lose less protein and that will improve because as you're losing albumin, you're potentially losing this factor that's kind of keeping water and other plasma inside of the bloodstream. So that will help. But the biggest thing is oftentimes just restricting sodium to some degree, because if you cause them to have a lot of sodium, that can also cause them to retain a lot of fluid. So I'd say a degree of salt restriction to a degree. But oftentimes these patients, you got to give them diuretics, like loop diuretics. And I've noticed these patients, you have to give them like heavy doses. I would consider this diuretic resistant kind of a disease. And this is oftentimes what happens is you get patients who come in, they have heart failure, or you think that they have heart failure. They have pulmonary edema, they have a peripheral edema, and you give them just tons and tons and tons of furosemide, and you're just like, man, I can't get this fluid off. Oftentimes that's when you start thinking about nephrotic syndrome. So this is one where I would give them sodium restriction and I would start hitting them with pretty heavy doses, like 2 to 3 times your normal dose of furosemide for these patients. All right. So that's how I would do that one.
Cool. Next one is hypertension and proteinuria. How would you manage that?
So hypertension is more common in nephritic syndrome, but it can happen in nephrotic syndrome because of the renin-angiotensin-aldosterone system activation. So the best thing to do is suppress the renin-angiotensin-aldosterone system. And so ACE inhibitors, ARBs, are really, really good at this because you're basically blocking angiotensin 2, which is the one that can cause this higher blood pressure and sodium and water retention. Proteinuria, funny enough, ACE inhibitors and ARBs as well. And so what's great about these drugs is what they do is they block angiotensin 2. Angiotensin 2 has an effect in being able to cause vasoconstriction and increase ADH and aldosterone production. So if I block that, that'll bring my blood pressure down. The second thing that it also does is it causes the efferent arterioles to vasoconstrict. And so if I block that, they'll dilate, and that kind of reduces the pressure inside of the glomerulus, and it makes it easier for blood to leave the glomerulus, and so the pressure isn't so high that it's filtering out lots of proteins. And so that's one thing I would also see is that this can help to reduce proteinuria. So edema, I give the furosemide, and then hypertension and proteinuria, I give ACE inhibitors and ARBs.
Okay.
Or ARBs, sorry.
Yeah. How about the hypercoagulable state?
This one's a tough one. So these patients are high risk for DVTs, PEs, and if they have a DVT or PE, I'm starting them on anticoagulation, especially if they have nephrotic syndrome. But let's say that they've never had a provoked VTE, so they've never had a DVT, PE, or anything like that. Then it's more about kind of stratifying the patient and determining their risk. Because if you start somebody on an anticoagulant, you put them at risk of bleeding, but you also want to do the purpose of it, which is prevent them from developing clots. So if a patient has risk, so what the guidelines I think say according to KDIGO is that if a patient has risk factors, malignancy, taking oral contraceptives, obesity, prolonged immobilization, etc., and they have a very, very low albumin, let's say less than 2.5, that really brings about the risk that these patients are super high risk for complications like a DVT, PE, and the biggest one, which funny enough, you see it with membranous nephropathy, is renal vein thrombosis. So in that scenario, I'd start them on anticoagulant. You can do warfarin, you can do heparin. There is newer research that's saying that suggesting that DOACs can even be helpful as well. But from what I've seen, usually warfarin is kind of the preferred one in this particular scenario.
How about the higher risk of infections?
So this one's more just preventative, right? So in the sense that like you're not going to particularly treat them with prophylactic antibiotics. They are at high risk for pneumonia. They are high risk for spontaneous bacterial peritonitis, but really you're just trying to reduce the risk of them developing infections, especially pneumonia. And one of the things is that pulmonary edema can create kind of a nidus for bacteria like strep pneumonia to grow. And so you actually want to just make sure that they get their pneumococcal vaccination and influenza vaccination just to prevent the risk of them developing infections. But I'd say the heaviest one is that pneumococcal vaccination. That's a really important one.
How about hyperlipidemia? Is it just lifestyle changes or are we medicating?
You can do lifestyle changes. Oftentimes treating hyperlipidemia in these patients is the same kind of guidelines that we would employ for any other person who has high cholesterol or high LDL. We say LDL greater than 190, you get started on a statin. If it's, particularly a patient who's 40 to 75 years of age and their risk is relatively high for atherosclerosis, then we start them, especially greater than 7.5%, we start them on a statin. If they have diabetes and they're 40 to 75, we start them on a statin regardless of what their risk is. And then if you have any clinical atherosclerotic cardiovascular disease, they had an MI, they have PAD, they have a TIA or a CVA, then you get started on a statin.
Got it. All right. And the last one is really just the treatment of the underlying cause.
Yeah. So if this is membranous nephropathy, that's really the key thing here, is that a lot of the times everybody thinks, oh, it's just immunosuppressants. That is true if it's primary. So if you've ruled out secondary causes, for example, minimal change disease is one of those that they say, oh, you start steroids, edema just melts away and they get better. That's true if it's primary, but you have to rule out the secondary causes. Same thing with focal segmental. If it's primary, you put them on steroids and immunosuppressants, they'll get better. But if it's secondary, you're not going to help them. And so you have to figure out the underlying cause. If it is primary, putting them on a good dose of corticosteroids, adding on an immunosuppressant for a long-term control. I'd say the best one, the most kind of like tried and true one, is cyclophosphamide. You can also consider things like mycophenolate, mofetil, and then even tacrolimus is another one as well. But oftentimes, more than not, putting them on a steroid and cyclophosphamide for membranous nephropathy is going to be the go-to. Focal segmental, kind of same thing. You can put them on a steroid, see how they do. If they don't respond well to the steroid, you can either use a steroid plus tacrolimus is also preferred. Minimal change, you just put them on a steroid. Diabetic nephropathy, you treat the underlying cause, improve their diabetes, strict glucose control. Amyloidosis, you treat their underlying disease of amyloidosis. It's just really important if they have, like, for example, let's say they have membranous nephropathy and their hepatitis B was positive, you don't put these patients on steroids. You treat the hepatitis B.
Yeah.
If they have HIV and they have FSGS, you treat the HIV. So it's important to know that it's not always immunosuppressants. It's treating the underlying cause. If it's primary, it's immunosuppressant. If it's secondary, then you treat those underlying diseases.
You got to dig a little deeper.
Exactly.
All right. Well, let's move on to case 2.
Let's do it.
All right. So we have a 65-year-old woman presents to the clinic with fatigue, swelling in her legs, and difficulty breathing at night. The patient has noted significant and progressive swelling in her legs extending to the ankles and lower legs over the past 3 months. Recently, she has required multiple pillows to sleep due to difficulty breathing when lying flat. She also reports a marked decrease in urine output and describes her urine as increasingly dark and frothy. Yuck. The symptoms have rapidly intensified over the last few weeks. Past medical history, she has type 2 diabetes, hypertension, hyperlipidemia. Medication she's on is metformin, lisinopril, amlodipine, atorvastatin, and an insulin. Exam. So her vitals, BP is 170 over 95. Yeah, her meds ain't working.
Yeah, you're starting to wonder, right?
Heart rate is 88. Respiratory rate is 18. Temp is 98.2. And her O2 sat is 92% on room air. General, she's an obese female, appears exhausted. Cardio, she has a regular rate and rhythm. S4 gallop, but no murmurs. Respiratory, clear to auscultation bilaterally, no wheezes or crackles. Abdominal is soft, non-tender, no bruits. Her neuro exam is alert and oriented, no focal deficits. And her skin, like before, the other patient, is dry, excoriated skin, scratch marks present, but no rashes. We get some lab findings. We have a creatinine of 4.5. This is up from 2.0 2 months ago. BUN is 80. Potassium is 5.6. Sodium is 132. Phosphate is 4.8. Calcium is 8.4. We get a UPCR again, like before, and we get 2.5 this time.
Okay.
Albumin is 2.9, and her GFR is a shocking 15. That's in the shadow right there.
Yeah, she's fucked.
She's fucked. We also get a urinalysis with microscopy. The following results appear. Color is dark brown. Appearance is cloudy. Protein 3+. Blood 2+. Red blood cells, we have 20 to 30 per high power field. White blood cells, 5 to 10 per high power field. And we get red blood cell casts that are present. We also do some imaging studies. Like our first patient, we get a renal ultrasound and an echo. In this patient, the renal ultrasound is showing bilaterally small kidneys with increased echogenicity and loss of the corticomedullary differentiation. Echo, just like before, we have a left ventricular hypertrophy and normal EF. So Zach, based on the above information, I would like to go in that stepwise approach again.
Yeah.
This one's going to be pretty obvious. Does this patient have nephrotic or nephritic syndrome? But more importantly, why?
Yeah. And so this is nephritic syndrome. And there's a couple of reasons why. So first thing I always say is look at the urine protein creatinine ratio. If you have a 24-hour urine protein, one of the two, and look to see if it's nephrotic range or not. That you got to be careful. There is two disorders that can have nephrotic range proteinuria and still be nephritic syndrome. And that's why people sometimes hate this disease. And that is lupus nephritis type 4. And then the other one would be membranoproliferative glomerulonephritis. And so that is possible to still have it, but there's other things that we look at anyway. But for the most part, it's usually sub-nephrotic range. And so it's less than 3.5. In this case, it's 2.5. So it's sub. So I'm going to go with that being kind of more likely to lend to me nephritic syndrome, but that's not all I need. The other thing I like to see is any evidence of edema. And so the patient does have some edema based upon how they were talking about in their HPI.
Yep.
And it's usually not going to be as bad as nephrotic syndrome. So it's usually going to be a little bit less intense. But the real big thing here is the blood pressure. Hypertension is a really common one.
Right.
And so usually these patients have pretty high blood pressures that are usually kind of like sometimes refractory to maybe a couple different antihypertensives.
I was going to say, even though they're being controlled, it's not doing anything.
Yeah. So they're on the Cinepril, amlodipine, still high BP, right? So that's pretty common. And that's one really big feature. So if a patient has subnephrotic range proteinuria, maybe some edema, but not to the level of nephrotic syndrome, but they have really bad high blood pressure. So hypertension, that's starting to make me think about nephritic syndrome. The other thing here that's really making me think about it is the really bad kidney injury. So oftentimes we look for a very concerning finding with nephritic syndrome, which is called RPGN. It's called rapidly progressive glomerulonephritis. And that's usually whenever their renal function like significantly increases within like days to weeks, sometimes months. And it's very, very quick. And so that's very concerning. And I see that the creatinine went from 2 to 4.5, BUN's up to 80. They even have a little bit of a derangement in the potassium slightly. So, and their GFR is down. I'm kind of nervous that they have a kidney injury. And so if I start seeing things like oliguria, azotemia via the elevated BUN creatinine, I'm starting to be potentially concerned about RPGN or acute kidney injury. So hypertension, acute kidney injury, potentially RPGN, and then on top of that, subnephrotic range proteinuria and the edema, that's my initial thoughts. Yeah. What I really go to is the urinalysis, and that's going to be my bread and butter here that's going to tell me about it. I see here that they have a lot of blood in the urine, so there is hematuria, but I look at the red blood cells, they got 20 to 30, so that's a pretty good amount.
Yeah.
So if they're having that much red blood cells in the urine, they have hematuria.
And red blood cell CAS.
Yeah, that's the giveaway. So if I look at their actual CAS and I see red blood cell CAS, or I see dysmorphic red blood cells, that's usually the giveaway that this is likely kind of a nephritic syndrome or glomerulonephritis. So biggest things here is the subnephrotic range proteinuria, the hematuria with red blood cell CAS, the hypertension, and the acute kidney injury suggestive of RPGN. That's the things that are making me think that this is definitely nephritic syndrome as compared to the nephrotic syndrome.
So let's move into then how you determine what the cause of this nephritic syndrome is. Kind of some specialized lab testing, maybe a biopsy. What do you do in that situation?
Yeah, so right away, I think this is definitely like nephritic syndrome. So my differential at this point is I kind of think about it in groups. So I think about, usually what's called, the first one, we're going to call it type 1. We'll say this is a linear type. So this is usually antibody mediated. And the primary antibody is called anti-GBM antibodies. And so if these are positive, it makes me think about anti-GBM disease or good pasture syndrome. The only way I differentiate the two is good pasture involves the lungs and anti-GBM does not. The second one is posse-immune, and this is usually ANCA vasculitis. So these are antibodies that are generated against usually neutrophils, and this can also cause a pretty nasty injury. And so ANCAs, if they're positive, if it's C-ANCA positive, it makes me think about GPA, which is granulomatosis with polyangiitis. And if it comes back positive or P-ANCAs, then I'm thinking about potentially EGPA, which is your Churg-Strauss or eosinophilic granulomatosis with polyangiitis, or MPA, microscopic polyangiitis. And so that's kind of what I would think about for that one. If those don't come back or yield anything, then I would start thinking a little bit more about immune complex deposition. And so I go through post-streptococcal glomerulonephritis. So I look for a history of recent strep infection, but I'll order titers that suggest a potential exposure to strep, such as an anti-ASLO and an anti-DNase B antibody. Second thing is I'll rule out lupus nephritis type 4. So I'll check an ANA and an anti-double-stranded DNA because that can also cause this. And then the other thing is membranoproliferative glomerulonephritis. This one can actually very commonly be due to hepatitis, especially hepatitis C and B. So I'll check those and I'll check a C3 level. And the reason why is post-streptococcal glomerulonephritis, MPGN, and lupus nephritis cause massive consumption of C3 complement proteins. And so those would be pretty low if one of those were positive. And then I could check a nephritic factor. That could be this super rare little a little SOB that binds the C3 convertase and causes dense deposit disease. Super rare, but if I wanted to, I could check that one and make sure that that one's potentially not positive.
At this point, you might as well just throw it in there.
Yeah.
Let's just throw it in and be thorough.
Yeah. And then I get the biopsy, and the biopsy is going to be the best thing for me because it'll tell me right away, most likely what's the cause. And I would look at it under light microscopy to see if there's glomerular crescents, because that's what I'd be super concerned for. I'd look at the immunofluorescence to see the pattern. So if it's granular, linear, or if it's pauci-immune. And then lastly, I'd look at the kind of the electron microscopy to give me a little bit better idea if there's any deposition or immune complex deposition. So that's the way that I would kind of do all of these things in kind of in tandem.
Cool. All right. Well, we go ahead and get those labs.
Okay.
And we get the following back. The ANA is negative. The anti-double-stranded DNA is negative. We do an HBV, HCV, HIV, syphilis, all negative. The P-ANCA, C-ANCA are both negative. The anti-ASLO or the anti-streptolysin O, negative. The anti-DNA B is negative. C3 and C4 levels are normal. We do get the anti-GBM antibodies, which comes back positive.
All right.
You think you have your answer there?
Yeah, probably.
All right. And then we throw in that nephritic factor, that comes back negative. For the really important one here, kidney biopsy findings, we do the light microscopy. It shows glomerular crescents found in several glomeruli. The immunofluorescence, linear appearance of IgG along the glomerular basement membrane. So I think we have a pretty good idea of what's going on here, Zach.
Yeah.
Now that we have this great lab workup, we have everything we need. What do we now have to? What tests are the most important in identifying nephritic syndrome?
Yeah, I think we hit a lot of these, but I think the big thing here is our serology kind of yielded us the best result, which is those anti-GBM antibodies that they came back positive. And so that definitely kind of gives me the idea that this is either anti-GBM disease or Goodpasture syndrome. It would take a little bit of clinical correlation to look and see if they have any alveolar hemorrhage or any hemoptysis or anything like that. Nothing's really mentioned in the history that I remember. And then there's no kind of chest x-ray to really suggest if they're having like infiltrates in their chest and stuff. So I would kind of be going out a little bit on a limb and say it's anti-GBM disease. Either way, it doesn't matter. Yeah. You're going to kind of treat them both the same in that concept.
But that does seem the most likely of course.
It seems more likely to be anti-GBM. And so that's what I would go with. And I'd say that the labs kind of tell me that since the ANA, anti-double-stranded, came back negative, no lupus nephritis. All of the infectious panel came back negative. It kind of lends to less likely a membranoproliferative. ANCAs came back negative, unlikely ANCA vasculitis. The anti-ASLO and DNase B, negative, unlikely post-streptococcal, and then there's no history of strep infection within the past 2-3 weeks. C3, C4 normal, no immune complex likely that's occurring here with, PSGN, as well as membranoproliferative, as well as lupus nephritis. And then the nephritic factor is negative. There's no type 2 MPGN. The light microscopy is actually kind of helpful.
Yeah.
It tells me they have glomerular crescents. That means that this patient probably has rapidly progressive glomerulonephritis. And that's usually, most often, patients who present with RPGN, it's almost always due to anti-GBM disease or Goodpasture or ANCA vasculitis. They most commonly present with RPGN. Okay. And so that tells me that they're probably experiencing RPGN. The immunofluorescence, if it's linear, it's always anti-GBM or Goodpasture. If it's granular, it's immune complex. And if there's nothing, like you don't see anything, that's ANCA vasculitis. And so that right there, it kind of just is a perfect setup for that this is likely anti-GBM disease.
All right. So like we did with case 1, let's talk about managing some complications. The first 3 here are very similar to case 1. Now, I'm just curious if there's anything different in talking about edema, hypertension, proteinuria.
No, it's really the same thing. You edema, you kind of restrict sodium, loop diuretics, pretty heavy doses. Hypertension, proteinuria, ACE inhibitors, ARBs. That's really the biggest thing.
Cool. All right. So that stays the same, easy to remember.
Yeah, I know. Thank goodness.
The next one is, though, talking about this AKI the patient's experiencing. How do we manage that?
Yeah. So acute kidney injury is a pretty big one. Obviously, it's a lot of this time this is an intrarenal AKI. And so you have to treat the underlying disease. And so that's one thing that I would have to get on top of. But also I have to be very, very vigilant and keep an eye on them developing complications, because you can treat the underlying disease, but that's not going to stop the AKI from continuing to potentially cause complications to arise. So in other words, if I started this patient on all the immunosuppressants and plasmapheresis and their AKI continued to get worse, I have to have a backup plan.
Yeah.
And usually that's indications for dialysis. So I would do my best to manage these patients medically first. If they have an acidosis, give them bicarb. If they have hypervolemia, try and give them heavy doses of loop diuretics. If they have hyperkalemia and hypervolemia, volume overload, I give them loop diuretics. But if they start developing signs of like uremia, they're refractory to my medical therapy, then I'm going to start saying, okay, we should probably start dialyzing this patient. So that's really the best thing, is to, again, you have to treat the underlying cause because you don't want them to continue to progress. But if they develop complications of the AKI, that treatment of the underlying cause isn't going to stop that. It's going to prevent the progression. I got to be ready to treat the complications of the AKI.
So you have your backup plan.
Exactly.
All right. Well, that's a wonderful summary right there of a nephrotic versus nephritic syndrome. I think that really handles this perfectly. I feel like I know them much better now.
Yeah.
It was a pretty cool discussion.
Thanks, man. Yeah. Oftentimes nephritic syndrome is a tough one. There's always so many things behind this one. And again, I think at the end of the day, same concept, nephrotic syndrome is a lot of this stuff. You can hit it with immunosuppressants. You just have to make sure you're treating the underlying cause. So like we talked about, anti-GBM disease or good pasture, ankylosing, those are pretty much always like steroids, cyclophosphamide, maybe some plasmapheresis. All the other ones though, except for IgA nephropathy, PSGN, those ones you don't even do anything. You just let them go. They usually get better.
Okay.
And so for those ones, I wouldn't worry too much. But for this one, this patient's going to need a lot of therapy. And I think that they'll turn the corner.
All right. Well, that really concludes this episode on glomerular diseases, including nephrotic versus nephritic syndrome.
Yeah.
I thought it was really awesome. It was a great episode. Thanks,
you, man. Thank you.
Yeah.
All right. Well, Ninja Nerds, thank you guys so much for listening to this podcast. And I really hope that you guys enjoyed it. I hope that you guys, also enjoy watching the video if you guys are watching it. If you guys have a second, go check out our website. On our website, we have a lot more things that we can offer. So things like notes, illustrations, videos. If you want to learn a lot more, we'll have that available to you guys. But Ninja Nerds, we love you. We thank you. And as always, until next time.